Ladies and gentlemen, let me take you to a journey into Africa and introduce you to Catherine. Catherine is a mother of two children, two beautiful children, and married to her husband and living in the north of Kenya in the village of Kikuyu. Their home has no electricity, has no running power, and infrastructure is extremely poor. The birth of her first child was very difficult. Whenever she had to do antenatal checkups, she had to walk to the next clinic and had to wait for hours for the next doctor or the next nurse. Then, one night, she went into labor. The area around the clinic is not very safe, so she had to ask her husband and a neighbor to walk with her to make sure she was safe. Once admitted in the clinic, the nurse left. She was alone, but she was in pain. Contractions came in, so she was calling for a nurse. But nobody came. It was only hours later, when the child was finally crowning, that the nurse appeared and helped her through birth. The doctors never showed up. Imagine being Katrine. Imagine living in a place where you're afraid to walk by yourself to a clinic. Imagine doing that in the middle of a night, or in the blazing sun, or in the middle of a flash flood. Imagine coming to the clinic only to find out there are no nurses, no doctors, no medication, or no medical equipment to take care of you. And finally, imagine you give birth, and they can't take care of you. So you have to walk all the way home, put your baby in your room, and risk the life of yourself, but also of your baby. The story of Catherine is a story we hear all the time in Africa. There are millions of women in Africa. They don't have to imagine being Catherine. It's their reality every single day. It's a very harsh reality. According to the World Health Organization, 1 billion people don't have access to primary health care. That's why we see figures like 8 million children dying of preventable causes every single day. It's those vulnerable ones, the women and the children of Africa, that suffer the most. And through my work, I have the privilege to listen to many of these brave women and to understand the stories. And we take that input into what I call a primary healthcare strategy for the continent by a big multinational company, usually doing work on different levels of care. But it helped my team to assess what is required. And it became very obvious we have to do it differently. Traditional ways and traditional approaches don't work anymore. And we have to partner, we have to open up to ecosystems. But most important, we have to listen. Listen what is required, listen what kind of care we need. Before I tell you about that journey, because this is what the talk is all about, let me introduce to another person that is very important to my life. This is my son, Leandro. He was born here in Johannesburg in a private clinic. We had to go through a C-section, not by choice, but we had a medical case before. We never felt actually insecure because we knew we had access. We knew the doctors, we knew the clinic we were able to afford. And then on the day of the birth of my son, my wife went into the operation theater and I was standing next to her. Then all of a sudden, like clockwork at 6 in the night, darkness, load shedding. I think you all know what that means in South Africa. And that was in the middle of the procedure. Pretty scary. But the good thing was the backup systems kicked in, the procedure was finished, and my baby son was born. Just imagine how that is if you're not in a private clinic. It's very different. And for me, it was very telling, actually. If you're at the right place with the right people and you trust the system, you don't have to be afraid. If that would be only true for everybody, if that would be only true for all the women of Africa, they could feel safe like my wife did when she gave birth. If that only would be possible for all the children of Africa to have a similar safe start into life as my son had. Unfortunately, we are not. The World Health Organization estimates that more than 300,000 women die every single year during and after birth. That's more than 800 women every single day. That's a shocking number for me. And most of these maternal deaths, they occur in developing countries. Most of them in sub-Saharan Africa, and most of them in rural areas or in very poor communities. This is part of why we actually were thinking, how can we change the whole situation? And this is actually what the reality looks like. And I show you these pictures by purpose, because many times we think there is care out there, and we talk about access to care, but what is lacking is quality of care at the end of the day. So when my team travels a lot into the continent, we see exactly those pictures you see behind me. Infrastructure that is not working, no medication, no doctors, no nurses. And the women of Africa are supposed to deliver, to be treated in these facilities. But infrastructure is only one element that doesn't work. You also have the element of distance. We saw that very clearly when we were talking to women in the north of Kenya, where they have to travel for 50 kilometers to reach the next clinic to get care. And just imagine doing that pregnant and on the back of a camel, because that's the means of transport in the north of Kenya. So we were thinking, how can we change? How can we go after this problem far more holistic than just bringing a product? With whom do you need to partner? To whom do you need to listen? And what we came up was an approach, what we call the Community Life Center platform. And I stress the word platform, because it's not about a ready-made clinic. It's not something you buy from the shelf. It's something you put together. Think about the concept of Lego blocks. I think we all know when we play with our children. It's about putting elements together to get whatever you aspire to have in front of you. And we do that the same. Our Lego blocks are buildings. Our Lego blocks are water, waste components. There are IT, connectivity. It's about training. It's about making sure that the clinic's sustainable. You bring business models, funding models. So all the elements that at the end, something is sustainable. Let me show you how we do that, because we cannot do it alone. That's I think, one of the key takeaways. Because even a big company like mine, which is globally presented in the health space, needs partner, needs a very strong ecosystem to make it happen. And let me take you into a county in the very north of Kenya. This is Mandara County. Mandara County is very close to Ethiopia and to Somalia. And it's a very harsh environment. It has a very high maternal death rate. We're talking about 3,800 women against 100,000 live births. Just to give you a comparison, the average in Kenya is 400. That's 10 times as much. And if you travel into Western Europe, we talk about 7. In the Netherlands, or 3.5 in the UK. So a figure that is really shocking, and some people talk about Mandara being the worst place when it comes to maternal death. So that's where we put our thinking line together. We were sitting together with the United Nations Population Fund, with the local county, with the local community, to come up with a solution that can impact basically child and women mortality. And it all starts off with actually sitting with the community, listening to the people, trying to understand what their needs are, try to understand what the needs of the caregivers and the women. And once you have a first concept, then actually you start executing what you believe is the right thing to create an impact. We had to refurbish the buildings up there, just to make sure that we have at the end a clinic that works. We had to put waste and water inside and put all the infrastructure in place. We brought new medical equipment dedicated for the mother and child courses. And those equipment now enables for diagnosis, for treatment, and for referral. And all is integrated into an improved workflow. Because at the end of the day, what you want is you want to have care at the right point, transfer people to the right places in case of complications. We started with training of the doctors, training of the nurses. We use partners like AMREF to doing that. And of course, we start to educate the community, because a lot of times, one of the key factors is lack of information, knowing actually what you need in order to be safe. We started equipping community health workers. Those are those who go deep into communities. So you try to bring care to the homes, very close where women live, activate them, reach out, and make sure you get the whole community involved. And then last but not least, Mandara is a county where there is actually no electricity. Everybody lives off the grid. That's a situation for maybe 600 million people in Africa anyway. So you bring a power solution. You bring something that helps to keep the system running. You bring something that helps to bring security. within the clinic, outside the clinic. And so this is the clinic what is running today. We launched it about 6 months ago. It's one out of many clinics, and it already shows a big impact. And what it has done actually changed the life of 40,000 people. I think that's the thing, it keeps me going every single day, if you can have a meaningful impact. Now, when you do these interventions, you face a lot of challenges. And especially when you're in Africa or in any underserved market, these challenges are around the corner every single day. And I just want to give you an example of what it means. So let's go from Kenya into the center of Africa, into the Congo, the very north of the Congo. And here you see a little outpatient clinic, which we put in place together with the local partners to provide maternal and child services. It's a wonder for me, it's a miracle for me actually that the clinic is there up and running and creating impact, because the journey from the clinic from South Africa over Kenya into the Congo was a long journey. We had to battle all the weather conditions and everything that hits you on the way to get there. And when we arrived finally, we found out the crane was missing. So how do you put the clinic down actually? How do you make the system work? The beauty about Africa, I find, is people are creative. People are innovative. And therefore, what happened actually, it's the community, it's my team, it's the logistics teams, they pulled together. They actually went into the bush. They chopped down some trees, they built a wooden pulley to pull the clinics down and put them on the foundation. And they were so precise, they were a centimeter off. So actually, you don't need fancy technology. You can make it happen with something as simple as a couple of trunks of trees. It just shows you what we can do if we work together with the community. Now, where are we these days with our project? I want to show you a clinic. This is the clinic in Kiambu County. That's a neighborhood very close to Nairobi, a township, if you want to call it. And we're running this since 36 months. And the results are encouraging. We see that antenatal visits have increased from 6 to about 145 on an average. And that gives you a good indication women are coming. We can detect actually complications. We see visits increasing from below 1,000 to almost 2,000. And bear in mind, these numbers are highly impacted by the strike ongoing in Kenya. For those who don't know, Kenya is on strike since 2016-17, the doctors, the nurses, the medical staff. We have seen months with 4,000 as well. So you see a positive trend, and again, the challenge around the corner. And what we see as well is we see deliveries happening. Women no longer avoid the clinics because they don't feel safe. They come to the clinics even in the night to deliver babies. So we see 30, 35, 40 on a monthly basis as well. That's very encouraging if you get that kind of figures coming through in your clinics. But even so, we are trying to test actually these clinics in very different environments. And you see here just a summary of a couple of them in the collage behind me. Different clinics, different services in different environments, urban and rural, with different partners. We are collaborating with the Red Cross, UN organizations, with the private sector, with foundations here in South Africa as well, with banks, just to see how can we get it going, what is the right mix. Because one thing I've learned in that journey, we all have to open up. We all have our own processes, we all have our own way of working, and you need to overcome that. Oops, sorry, let's go back. We need to overcome that. For me, right now, we're on a stage where we can go global, where we can go actually in scale. And what I mean with that is, we have now a modular approach, which I can put together the way I want it. But I need partners, because I can only provide certain elements of that. But I also need partners on a global level that can provide me with business models. They can look into different funding opportunities. They can help us actually to bring the topic onto the discussion platforms of this world, to push it forward at the end of the day. So that's the journey what we're in. I think in 2 or 3 years from now, I can stand here again to tell you where we are. But I believe strongly this is a responsibility for everybody, creating access and especially quality access to care. I also believe it's a very holistic approach. If you don't look into the whole thing end to end, but you only look at single intervention, it's not going to work at the end of the day. And we see that today. And it's a sustainability approach. It's about working together and making it happen. Let me come back to Catherine at the very end, where I started off. And this is Catherine now again, but in a very different setting. She lives now very close to one of our clinics. And her second-born, Louis, the little child here on her arm, was born in one of our clinics. And this time she got regular checkups during the whole pregnancy. And then when she went into labor, and usually it happens at night, she actually was able to walk to the clinic. And why was that? Because the clinic provided security lighting. And with security lighting, if social economic activities popped up, we had shops everywhere and we had people everywhere. And therefore, it became finally safe to leave her child with a neighbor and simply walk to the clinic. That's when she was taken into the maternity ward, looked after, monitored over the whole period before, during, and after the birth, and kept for another 24 hours, simply to make sure no complications would occur in the aftermath. If the story of Catherine tells us something, then if we work together and listen to those underserved communities, we can really make a tangible difference in the way we serve these communities. And then maybe one day, for all the good reasons, we might be able to go back to the women of Africa and tell them, imagine being Catherine. Thanks a lot.